Good morning, I'm Deborah Marshall, and we're excited to share with you our study about an individualized online decision aid for patients considering knee arthroplasty. There are over 75,000 knee replacements in Canada, and over 90% of these are for osteoarthritis. And the rates continue to increase with an increasing number of younger patients at lower severity. And critically, 15 and even up to 30% of patients report dissatisfaction or no improvement in symptoms next. In our best evidence for surgical treatment for knee arthroplasty, or more affectionately, our best knee study, which was a prospective cohort study with almost 1,300 patients, we confirmed that preoperative expectations are significantly associated with level of satisfaction at 1 year follow-up post-surgery. So ensuring that patient expectations are achievable may enhance appropriate provision of knee arthroplasty. Next. These are our previously published appropriateness criteria, and of the 6, 4 of these are from patients, and both symptoms and expectations are important factors that affect appropriateness. Next. Previous studies have shown decision aids can facilitate shared decision-making and improve appropriateness of surgery. However, in those studies, the decision aids used average information on surgical outcomes that might not be accurate for individual patients. So we aimed to determine if a patient decision aid, which provided individualized outcomes that are based on PROMS data, would improve decision quality and change surgeon uptake in routine clinical care. Our primary outcome was the proportion of patients making quality decisions as measured as the extent to which patients are informed and receive treatments that reflect their goals and treatment preferences. Next. This was a randomized controlled trial with half of the patients receiving the decision aid and others not. And it was embedded in routine care at the Edmonton Bone and Joint Clinic in Edmonton, Alberta. And all patients completed online pre-surgical PROMS assessment. And then in the decision aid, the individualized PROMS were based on historical data from Alberta, considering age group, sex, and body mass index. Part of the intervention included 2 items, which were added to the patient's file, 1 being the appropriateness checklist, and 2, the surgeon report from the decision aid to help guide decisions at the surgical consult. Next. This figure summarizes the study design in a simplified manner. In brief, at baseline, both groups answered knowledge questions, decisional conflict scale, and indicated their treatment preferences. Post-surgical consultations, patients reported their experience of shared decision-making in 3 different follow-up surveys, which included the Collaborate tool for patient-reported shared decision-making, generic and specific quality of life measures, and decisional regret, satisfaction, and expectations. I refer you to our protocol publication for all the details, and now I'll hand over to my colleague, Logan. Thank you.
Thanks, Deborah. So I'm going to talk through a bit about the actual decision aid itself and then some of the results. So this provides an overview of the PROMS-based decision aid, and I would just emphasize that this decision aid was developed with patients. So we conducted some focus groups to identify decisional needs at the start, and also some user testing through iterative processes, so we were able to refine the instructions, the information, and the graphics throughout. Briefly, the decision aid informs patients about the decision that needs to be made, ask them to compare themselves to similar patients who are considering knee replacement, presents information on 9 different common questions related to the decision, and this includes 5 of which are based on the actual PROMS. It then asks some follow-up questions and provides a summary for patients to consider whether they feel the benefits of surgery outweigh the risks. This information is then summarized in a 1-page preference report for the surgeon. But this is an example of the baseline risk graphic. This is a graphic that talks about the potential impact of surgery. So this is individualized based on that individual patient. So the summary of the decision aid, so patients would actually work through the 9 different questions, which are down the left-hand side. And it allows them to think about each of those as it relates to knee replacement surgery, non-surgical treatment, and whether or not they're actually unsure about how they feel about it. And at the bottom, it asks them whether they feel that the potential benefits of surgery outweigh the potential risks. Next. This is a brief look at the surgeon summary report. And so this touches on the patient's quality of life as it relates to joint symptoms there based on the PROMs. Also asks about whether they've had any types of preoperative management and what those might have been. At the bottom of the report, it'll ask about and present on their actual expectations. This is a brief overview of the actual trial. So we assessed over 800 patients for eligibility. Nick's going to talk a little bit briefly at the end about some of the challenges we actually had in recruitment. But we randomized 163 patients. And if we look at the characteristics of those patients, we find kind of what you'd expect. And so on average, patients were about 65 years old. But one thing to note here is that we did find a higher proportion of females in the decision aid arm, but we did adjust for that in the analysis. Next. And so as Deborah talked about earlier, our primary outcome was decision quality. And this requires that patients are both knowledgeable and what we call concordant, so that they make a treatment choice that matches their preference. And this is the outcome that's recommended by the International Patient Decision Aid Standards Collaboration. And so when we look at this outcome in the context of our trial, we found that those in the decision aid arm were at increased odds of making a quality decision. But if we dig in a bit further, we've got both the components of decision quality there, whether they were knowledgeable and whether they were concordant. And we can see that this increased odds of decision quality tends to be driven by the fact that patients are at increased odds of being more knowledgeable. So that the knowledge tends to be driving the decision quality. We did have several secondary outcomes that we were looking at as well, and we'll just touch on a couple briefly. One of them was the decisional conflict scale, and this is widely used in the decision aid literature. One of the questions to note here was around whether the patients felt that the benefits and risks of knee replacement surgery and non-surgical treatment, whether they understood them. And what we see there is an increased odds for those in the decision aid arm, which kind of matches the decision quality that we just talked about. And the second thing to note is the actual impact on treatment choice. And so we see that those in the decision aid arm had decreased odds of choosing surgical treatment. And this again is in line with some of the literature that suggests when patients are informed, they're more likely to choose conservative treatment options. And so now I'll hand it over to Nick.
Hi, so I'm Nick Bansback, and I'm just going to reflect on this study. I think the first reflection or lesson that we learned is the importance of spending time in the design of the decision aid. It went through many iterations before we launched, and probably we underestimated how much time that would take. But one of the positives from what we did was that we were able to use the existing infrastructure in Alberta, which was using REDCap to collect the PROMs. And so we were able to use the API and REDCap to connect to our software to make this feasible. But we also benefited greatly from the BEST knee study that Deborah mentioned earlier, where they'd already established trust and engagement with both the clinicians and staff in the clinics, which was a definite asset to the study. And then lastly, because Alberta has been collecting PROMs data for hip and knee surgery for so long, we're able to use this large resource of data to create these individualized outcomes for patients. But there were a number of challenges. The most notable one in terms of the numbers of people who we actually were able to recruit. We find only 30 to 40% of people actually complete the online PROM survey before the surgeon consult. And so this was a challenge for us because they needed to complete it online before they could actually go to the decision aid. And even though in the clinic, patients do complete the PROMs with iPads, there was not sufficient time for them to do the decision aid in the clinic. So therefore we had to exclude a number of potential patients. Another challenge was that we don't have the PROMs for the non-intervention group. So we collect PROMs for people who have surgery, but not for people who choose not to have surgery, which is an important outcome for people to reflect on. In terms of future directions, we think it's important to consider the benefits to patients for completing PROMs. Too many of these PROMs are used for quality improvement or system level improvements. And this is an example of how you can actually use the PROM to inform the patient and their clinician with the information that's being provided. But the reality is that full implementation of something like this, which is a real-time individualized feedback, is really challenging. And our study has highlighted a number of the deficiencies that make that a challenge. But we think that technology and a sort of patient-centered approach to PROMs collection in the future could potentially solve these challenges in the future. If you have or want more information, please visit this website at the top. but we will thank you and thank all the people listed here for their participation in the study.